Thank you very much. You know, as I was looking over the syllabus and hearing Gretchen talk and hearing what Lane's going to say next, a lot of this stuff is going to overlap, but really the important stuff is going to overlap. So I think hearing it from different perspectives is probably a very good thing. You know, this is a subject that's near and dear to me. I speak a lot on this topic, and I try and educate on this topic. But I think sometimes if you look at opioids themselves, we are led to believe, not only lay people, but also physicians, that opioids do such a great job for chronic pain, and they do such a great job as a standalone agent. And if there's anything these lectures are going to tell you is that that's simply really not the case, and that this chronic pain issue is a very complex issue. And going into some of that complexity and the psychosocial aspects is very, very important to get a grasp on these people. We're going to touch a little bit on opioid pharmacology. This is going to be touched later, but you know, most all opioids in clinical practice are full agonists. They're full mu agonists, and I think that's important to note. They have different affinities, and now we know that the mu agonist has got all kinds of different subsets, and we'll talk a little bit about that. But it's important, I think the most important thing to do is to understand the duration of action of the meds you're given. And we talk about most opioids. There's really only two opioids that have intrinsically long half-lives, methadone and levorphanol, which is rarely used anymore, but all others have about a 2 to 4 hour elimination half-life. And so if we look at that and we say, if we're using short-acting medications to manage patients, and some do well, but we also have to remember that at higher doses, patients will oftentimes take more medications simply to get the roller coaster effect smoothed out. And so we have to understand that that's why long-acting opioids do play a good role in compliant patients. The last thing you want to do is give a patient who overused their meds a long-acting agent. That's not good. And if you look at the long-acting agents, most of them are now once a day, twice a day, some 3 a day. Starting doses and conversion tables, I'll go into that in a little bit. Beware of conversion tables. Beware of starting doses. It's a tricky situation because opioids have what is termed incomplete cross-tolerance. One opioid does not equal another in equal-analgesic doses. Sometimes one has to go down on a dose because of this incomplete cross-tolerance. Gretchen covered side effects very well. Methadone is something I'll touch on and will be touched on later. I mention it here because it is intrinsically unlike most other opioids. It has, I'll give you some of the goods it has. It's a very good agent, well-tolerated agent. It has a very long half-life, although its analgesic half-life is much shorter, perhaps 4 to 6 hours. Methadone has intrinsic activity on what we call NMDA, which is the neuropathic pain state that occurs in the spinal cord. And therefore, with certain neuropathic pain states, methadone can be a very effective medication. Unfortunately, it's also a medication that is tricky, especially if you're converting it, especially if you're starting it. And methadone is really start low, go slow, because that's how people, if you look at the studies, they will tell you that most patients who die of methadone overdose, which is a major problem, do it in the first 2 weeks of therapy or within an increase in dose. So typically it's poor titration and it's overestimating or underestimating the conversion. Is pain undertreated? I think if you look at pain being undertreated, I think pain is perhaps undertreated the right way. We overtreat pain with pain medication. I'll say that up front. We undertreat pain with other modalities that can affect a patient. Psychological, physical therapy, manipulative therapy, analgesic medications that are non-opioids, adjunctive medications. All of these play an important role. But the important question is, does it? And I think if you look at it from an opioid standpoint, it is, we use too many opioids. Management of pain is really a multidisciplinary problem. If you're managing pain in your own private practice as a family practitioner, or internal medicine doc, you can still incorporate many of the things that I do on a regular basis. Adjunctive analgesics, psychological evaluations, getting patients into the right kind of physical therapy. Opioids cover pain. I tell my patients, opioids cover pain. They don't treat pain. We've got to find the cause of your pain. We need to treat that pain with other modalities. So opioids, I think, are overprescribed. Remember, chronic pain is very complex. Opioids alone are beneficial to 25 to 50% in pain reduction. We are taught in medical school that opioids have a ceiling effect, they have no ceiling effect, that we can keep increasing the dose and increasing the dose, and clinically that's simply not the case, and we'll talk about why that is in a little bit. Opioids are beneficial in a small subset of patients, small subset, and those patients, many patients would do well with discontinuation of opioids and then pursue other types of therapies. Now, how do we pick those people out? That's the problem, that's the concern. So there's no universal efficacy with opioids when we use them. Are opioids efficacious for chronic pain? If we look at, there's some evidence that in a small percentage of carefully selected patients, which we'll go into, these drugs are effective. But there's ironically more data that shows patients do better off of chronic opioid therapy than they do on. Most randomized controlled trials up to this point have been short-acting studies. There's not a lot of good long-acting studies out there that show the effects of opioids. And those studies are flawed because pain is subjective. Patients drop out more readily in a pain study. Tolerance develops, those kind of things. And so there are some long-term outcome studies, but most of them are short-term. Interesting Denmark study in pain of 2006, the Journal of Pain, talked about how their study showed that most patients on chronic opioids do better off. Is analgesic effect maintained over time? Again, that's the problem with some of these long-term studies, is there's a high dropout rate. And then you develop the issue of tolerance and hyperalgesia, which we'll see in a minute. So studies suggest a subgroup of patients may do well and may develop good improvement in functional levels with opioids. But a number of studies show that patients might do better off. So if we look at utilization of opioids, we have to remember that it's a constant, vigilant process, managing these patients ongoing. And we'll see the best outcomes in patients who have well-defined pain, realistic expectations, and minimal psychiatric and social issues. I think that's important when we talk about expectations. Patients who come to see me, or anybody who does chronic pain for a living, like Gretchen said, have a long failure list. And they will look for anything that will make them better. And you have to go into a patient and be realistic with them. I ask my patients, what is your goal by seeing me? I want to be pain-free. You've had pain for 20 years. You're not going to be pain-free. You'd be surprised at how many people think that and will chase that dream. But if you educate them and say, if you use these pain medications and if you use my other therapies and if you're going about trying to improve your activities of daily living and exercising and attending your therapies, you'll get better. Patients who get better have to make that determination that they're going to get better. And so much of it is teaching patients and discussing expectations with them. This is the clinical journal, or the Journal of Pain, the clinical guidelines. Again, we addressed it just a little bit, but it does, in the preamble, it does state that chronic opioid therapy has increased dramatically. You know, 15 years ago when I started practice, we gave lectures about how pain was so undertreated and how medications and opioids should be utilized and utilized. Now it's the reverse. The reverse now is that we're simply relying on opioids too much, and we're not relying on other adjunctive agents and other ways to manage pain. But they are reasonable for carefully selected and monitored patients. Monitored is the key word. Monitored is the key word to keep your patient out of trouble and keep us out of trouble. Opioids are associated with potential serious harms. Number one, diversion, abuse, and certainly adverse effects. So when we talk about chronic opioid therapy, the Journal of Pain, 2011, talked about chronic opioid therapy. It demands a compliant patient, a patient who follows the directions of their physician. A patient who wants to improve and has been discussed, his pain has been discussed to him in a realistic fashion. Documentation on office visits of all of the aspects of what you're monitoring. Pain relief, adverse side effects, any signs of abuse or aberrant behavior, and activities of daily living. Those are the things we look for. We want to always assess opioid-related side effects, primarily sedation. When patients come in, we have them give us a list of all the medications. They get tired of doing it, but we have them write them down every visit because I want to know if a family practitioner or a psychiatrist or somebody has placed this elderly lady on a benzodiazepine that could interact with the pain medication that I have her on, or my psychological patients who see psychiatrists and they get placed on, trazodone, or they get placed on some type of sleep med or Seroquel or something. That will cause a functioning patient on chronic opioids to go down real fast in regards to sedation and cognitive disruption. So it's important that we address risk stratifications. And you'll notice down there, like at bullet 4, physicians we don't have a lot of skills for risk stratification and pain management and risk assessment. And that's what I hope everybody learns today to a great degree, because understanding your patient before you place them on chronic opioid therapy is going to eliminate probably 90% of your headaches, in my opinion. Psychosocial risk assessment is mandatory. Every patient with chronic pain, most every patient, is depressed, they're anxious. What I want to know, though, is do they have a bipolar disorder? Do they have long-standing depression? Do they have any kind of personality disorder, such as borderline, which is very common in pain patients? Do they have any of those issues? Because all of those issues bode for a poor outcome. And so I think chronic opioid therapy should be viewed as a treatment of last resort. Last resort being that you've, number one, identified the source of the patient's pain, and you've tried other modalities in regards. Now, you can utilize chronic opioid therapy with the other modalities ongoing, but I think that when you reach for chronic opioids, it really should be down the line in regards to your choices. So what do we know? We've got to do a comprehensive physical examination, neurological and musculoskeletal primarily for these patients. I ask for all old medical records. I want to see them. I want to review them because it's important to know what that other physician has possibly tried, what other opioids they might have tried. Psychosocial issues, again, I keep harping on that, but it's so important. History of addiction, which Gretchen touched on very well. Close observation. This doesn't necessarily have to be monthly, but it should be at least quarterly. And I think that the close observation is important. Physicians get into trouble when they don't observe patients on a regular basis and they're prescribing opioids. Things can get out of control. Patients at risk. Again, there's that old psychosocial. And observation that I look for, a lot of poor eye contact, poor posture, poor interaction, very distant. They don't bring their families in oftentimes. I always know I'm in for a long visit when I've seen a patient for a year and then finally the spouse comes in or the parents come in because there's issues and somebody is not telling the truth, and it's usually the patient. Prior history of sexual and physical abuse, very common in women to have issues with addiction and abuse with a history of those problems. Poor motivation, lack of insight. Motivation of a patient is key. Lack of insight is key. Again, it all comes down to explaining what the goals are and reinforcing those goals every visit, every follow-up visit. Are you meeting your goals? Are you doing what you're supposed to do? You'll see after 2 or 3 visits whether they're interested in improving or whether they're not. And quite honestly, pain relief is not the reason we use chronic opioids. It is part of the reason, but the main reason we use chronic opioids is to improve activities of daily living and function. Disability patients, Medicaid patients, prior criminal activity all play a role. I like to call them the ideal patient and the wrong patient. The ideal patient is the 70-year-old gentleman with intractable spinal stenosis, failed epidurals, cannot have surgery because of his bad lungs and bad heart. He wants to be active. He wants to go out. He still likes to play golf and piddle around the yard. He wants to work hard to improve, and he's interested in looking at other interventions. He wants to know if there's anything else that can be done. He's not really focused on opioids. In all actuality, he kind of tells you, they kind of worry me. I don't really know if I want to be on them. And he has a good understanding with education that opioids can provide some relief. Now, the wrong patient is the patient that causes most of the phone calls, and they're the patient that causes most of the problems. Not every wrong patient stays a wrong patient. I think sometimes wrong patients can be made into ideal patients with appropriate physician education and addressing other psychosocial issues. But they have really kind of a diffuse and poorly localized pain. They may have the Waddell signs that Gretchen talked about. They may have a somatoform disorder. They may have kind of a fibromyalgia, chronic headaches, chronic myofascial pain type state. Work up, you know, they've been there, they've done that, they don't really want to do anything else. They kind of got a fear of needles. They don't really want trigger point injections or anything like that. They've been to physical therapy. They just kind of want pain medication. And perhaps they're justified in saying that because pain medication was the only thing that's ever helped them in the past. They'll tell you it may lower their pain score from an 8 to a 6, but they're quite convinced that opioids are the only way to get better. Again, they have poor insight and unrealistic expectation. That's the key. You can change patients. And they're poorly functional. Now, unfortunately, this involves a lot of patients who are on litigation. It's a lot of our younger patients, unfortunately. And I think that the wrong patient you have to pay attention to because they may just not do well with chronic opioids. So chronic opioid therapy, when we start, we talk about informed consent. We talked about that being not the appropriate term now. Discussion of risk and benefit, that's important. Sitting down and discussing with the patient. What's the benefit? What's the risk? They sign something, they look at something, it talks about all the risks that are potentially there. But I think the benefit is where physicians have to pay close attention to, and that is, what are we looking for? I want to see your ADLs increase. I want to see you doing more, functioning more, being a father, being a husband. I think a 4 to 12-week trial is appropriate. And this doesn't mean you continue to increase the opioids. The studies, the short-term studies will tell you that tolerance develops after about 2 months, and the doses have to be increased perhaps 20 to 30%. But after that, patients tend to stabilize out. So that therapeutic trial should not involve rapidly escalating doses, but rather starting at a moderate to low dose and perhaps titrating upward, but determining if the patient is going to get better and see improvement. Start low, go slow every time, not only for sedation, but also for other side effects, especially cognitive dysfunction, and we don't want to, and we want to be careful with conversion tables. Why the poor response? Why do you place a patient on pain medication and they're just not responding very well at all? I think the differential diagnosis that you probably maybe picked the wrong patient, maybe that wrong patient as opposed to that ideal patient. Certain pain syndromes don't respond as well. Diffuse generalized pain such as fibromyalgia, chronic headaches, diffuse myofascial low back pain oftentimes don't respond as well. The patient may have unrealistic expectations. That's one of the major ones. Are they poorly responding because they're abusing and diverting? Something that certainly must be looked into. You're not using a multidimensional or multidisciplinary approach. You're not using other modalities associated with your opioids. And perhaps opioid-induced hyperalgesia, which we'll talk about in a minute. But the biggest mistake clinicians make is continued escalation of opioids, despite the fact that patients simply aren't improving. And there is a glass ceiling, and once you hit that glass ceiling, that patient is going to suffer, and it's going to be a real problem, because it's always easier, it's never easy to try and decrease a patient who's been on pain medication for a long period of time. Dose escalations in high-dose opioids. High-dose opioids, defined by this Journal of Pain, is 200 milligrams of morphine or equivalent a day. So 60 milligrams of MS Contin, sustained-release morphine, is 3 times a day is borderline this, or 40 milligrams sustained release oxycodone 3 times a day. So when you reach that point, that's when you start to really have to worry about what's going on here, why is this patient not improving, why am I having to increase doses, and why should I increase over this dose? In the state of Washington, they passed a law that said that any non-pain practitioner who prescribes a dose of greater than 180 morphine equivalents a day, that triggers an automatic pain management referral. So there is a level that patients get to that things can become a little bit out of control. One of the things you have to look for is remember your differential diagnosis that we talked about, but the 2 major causes of worsening pain are worsening of the disease state and psychological deterioration. What about opioid rotation? Hit and miss. I think it serves a role. You know, there are different subsets on the mu receptors that are being identified on a yearly basis. I think that oxymorphone may work differently than oxycodone, which may work differently than morphine, which may work differently than fentanyl. Opioid rotation is certainly something, but when you opioid rotate, remember, when you convert to something, start lower than the equianalgesic dose would tell you in a conversion table because of the incomplete cross-tolerance and due to the fact that patients may just do quite as well with less opioid with the rotation. Tolerance and opioid-induced hyperalgesia. Hyperalgesia is something that's being talked about quite readily in the literature, and I'll give you a brief synopsis of it. It's probably a central spinal cord state. It probably does have it. Instead of a pro-nociceptive effect that opioids have, it's an anti-nociceptive effect. In other words, the more you give, the worse they get. And oftentimes, they'll show up looking like they have those Waddell signs. They're diffusely hypersensitive. They are depressed. They are not doing well from a number of levels. And this oftentimes happens when we get to the 200 milligram morphine, plus or minus that level. It also can occur when you rapidly escalate doses. And you have to pay attention to whether it's tolerance or not. I'm not convinced that clinical tolerance to opioids develops quickly after about a 2 to 4 month period. I think what happens is that with increasing doses, perhaps we are seeing some opioid-induced hyperalgesia, which is kind of seen as tolerance because you increase the dose, they seem to get worse. They must be getting tolerant, so I'll increase it more. Common mistake that I see. Difficult situations, my last slide. Remember, pain is subjective. Physicians are caregivers. They're not law enforcement officers. It is very, very difficult sometimes to play that role. We're taught to be empathetic. We're taught to be the proponent of the patient. It's very difficult to look at an OBN report and see that they're doctor shopping and go in and confront the patient. It makes a lot of us uncomfortable, as it should. But on the other hand, it's something that we have to do if we're going to prescribe opioids. What about lost and stolen prescriptions? My clinical practice, I don't refill them. I will treat the withdrawal, but I will not refill. And I will make them get a lockbox. And I will make them, I don't care about a police report. You can go file a police report for lost meds anytime. They don't matter. But I do make them get a lockbox. I do make them give us the receipt for that lockbox and make certain that that is in there. And I educate them. I bring them back and I educate them because you can't keep having that. That is either diversion, abuse, or just a poorly compliant patient. Pattern of abuse demands a response. If we see abuse, we have to do something. We are physicians who are, this is an epidemic problem of diversion, of abuse, of deaths. This is not something that we need to take lightly if we're going to do this in our practices. We have to look and respond to any signs of abuse. We may counsel the patient, we may fire the patient, we may do other things, but we have to document that in our chart. Why the poor opioid response? Again, your differential diagnosis. And really, honestly, counsel the patient. It's a long time. It takes a long time, and it's very difficult to sit down with a patient who is on high-dose opioids and tell them it's just not doing it. It's just not doing it, and we're going to start weaning back. Some patients take their pain medication to treat their mental pain. Remember that. They don't do it to treat their physical pain sometimes. They just want to be sedated. They just want to feel different, and that's why they take them. They're poor in sight and unrealistic. Again, touch those realistic expectations right off the bat, save you a lot of problems. And again, discuss alternatives as you're going along, not just at the end when you say, we can't do this anymore. Thank you very much.